Thank you for inviting me here, especially Dr. Pablo and Marco. And then it's a great city and a beautiful place and hospital. So I'm very, very honored. And then so I think everybody here, we are flowers, but beautiful flowers. But sorry, but I could not say everybody's name. Only I know the Dr. Pablo and Marco and Dr. Duki, and did I pronounce your name correctly? Duki. And then Dr. Miracole, and then Dr. Tomomori, right? Okay, Luis, oh, sorry. Yeah. Then Dr. Sanchez, oh, yeah. Yes. Yeah, thank you so much, all of you. And then I will start my talk. I felt a lot of, yeah, Dr. Sanchez, thank you. Yeah, sorry. Yeah, there are a lot of energy. I felt a lot of energy from Dr. Pablo and hot discussion, you know. So I'm very happy to be interrupted in the middle of my talk. So if you have any questions, please raise your hand. And then before moving to the next, I'd like to just clear, you know, what we know, what we do not know. Okay, that is my idea. So I put the past and present and future of the thyroid ablation, especially thyroid radiofrequency ablation, because I mainly use ethanol and radiofrequency energy to control the tumors. Yes, all the very nice people, and I already have very nice 2 dinners. Thank you. And then this is my first case. So always, you know, the first time is just so painful. Whatever it is going to be, marriage, you know, the school, and your first case, when I think back, it's always challenging. This was my first case. He was the professor in engineering department. So he was in pre-toxic, preclinical hyperthyroidism. Also, he had a heart problem. So his endocrinologist recommended radioablation, but he was researching the whole papers, how much percentage of hypothyroidism after radioablation. So that's why endocrinology gave him an answer like a 20-30%. Wrong number-wise, if you watch out you more, maybe a little bit more. So his idea was, okay, I don't want to lose my thyroid. So I like keep my thyroid. And then because he is a professor at the same university with me, and then he found my name through the Google. And nowadays, if you do not know something, first time I look for Dr. Google, where's my answer? So, and then he did a research, thyroid ablation, non-surgical, thyroid preserving. Anyhow, he found my name and then visit my clinic. So as you see here, there's 2 hot nodules. The right side one is big, and the left one is a little bit small. Yes, definitely his TSH level is far below than 1.0. But he's still, you know, T3, T4 is a normal range. He is suffering long period of time, like more than 10 years. So, and then this was a ultrasound scan. As you see here in the right side, thyroid node, there's a nodule with a vascularity. And then I treated him 3 years ago, first time. And then this was not thyroid dedicated probe. Nowadays, we have from Korean companies, there's a really dedicated thyroid generator and probes. So you will see in this afternoon. But this was a body procedure, developed for body procedure, and then anyhow treated. It was March 2016. The initial volume was 13, not that much. And then almost a year later on, 11 months, there was a volume reduction of the 50%. So in functioning thyroid nodule, rather than volume reduction, functioning regain, like euthyroidism is more important. So actually after my treatment, within a couple of months, his TSH rate level, regained gradually increased up to normal range. And then he felt much better. It was clinically, it was successful, but I wanted to follow up the volume of the nodule. So actually, he want me to ablate his nodule, but there was a insurance issue. And in the United States, I'll show you the guidelines, but still thyroid ablation, especially thermal ablation, not the chemical ablation. Thermal ablation is regarded as investigational or experimental. That means, insurance company will not pay the money. That means patient should pay the money. It is a lot, like $7,000 to $10,000 for a single procedure in the United States, as in US dollars. So that's why I sent my patient to, unluckily, Dr. Back, because in Korea it is $3,000 to $5,000 depending on hospital. So in Korea it's real. In Italy, as I know, also similar price, policy, like a $3,000 to $5,000 US dollars in Italy, in some, Korea, quite similar price. So, and then before doing, my patient for a second thyroid ablation, he measured the volume, he let me, and then 50%. Then after his second ablation in Korea, 2 years later on, the volume reduced to 80%. This is a very standard volume reduction after thyroid ablation. 50%, if you wait more, you can have 80% or 90% volume reduction. So this is a nuclear scan. As you see, the treated area is low, and then now we have a background radioiodine uptake in the thyroid. That's my first case. So now I move from topic to topic. So history of thyroid RFA might be, it will be a story about the whole past, why we are doing this, why all of a sudden, as a lot of people now have attention about thyroid ablation. And then I'll move to the current status of thyroid ablation, and then I'd like to discuss about what will be the future of the thyroid ablation. Whatever you like or not, now we are using Wi-Fi, all the social media. Thyroid ablation is the same like that. Whatever you like or not, within 2 or 5 years later on, your patient will ask you, do you do thyroid ablation or for me instead of surgery? And then you should have a tool. Otherwise, you should refer your patient to other physicians, other doctors. That's what's happening in the United States. In the United States, people, surgery, medication, other radioactive iodine, but now the patients are looking for doctors for thyroid ablation. So it is really, really important, going to be future within several years. So I'd like to talk about the history of thyroid RFA. So actually, thyroid ablation, rather than thyroid RFA, it is not new. As you see here, since 1990, over 20, 30 years, it has been tremendous research about the thyroid ablation, the result, clinical efficacy. And then you can ask, why all of a sudden now the thyroid ablation is going to be almost like a superstar or a rising star? The tipping point was always we have a new procedure, we need a guideline, very solid, kind of some instructions and data, something like that. So it happened by Korean Thyroid Radiology Group in 2009. In Korea, there's a very unique group like this group. It is called Korean Society of thyroid radiology. What they do is they do thyroid imaging and intervention. So, yeah, definitely it's a multidisciplinary group including surgeons and endocrinologists and radiologists. So they first published their recommendation in 2009 and then more and more. So we have a long history of thyroid ablation, but more active or vivid history is just 10 years. Or go back to their effort in thyroid ablation research, maybe 15 or 20 years. So today, I'd like to focus on why rather than how. So if you are really interested, you can find me, or you can find the right person like Dr. Pablo and Marco and Dr. Sanchez. You can learn how to do it. Today, I'd like to deliver a message why it is important, and then next will be what are the patient group, what is our target. That should be my main topic. So anyhow, patient wanted to preserve their thyroid. Okay, so always patient question is surgery only the solution or option, or is there any other ways, That's the very common question from the patient and family members. So there's a need for preserving thyroid gland. And the next one is, yes, as you saw, there's a lot of, I will talk more about advancement in techniques and then all the research and so equipment too, and then a lot of evidences. That's why now I'm talking about thyroid ablation, especially focused on RFA. So rationale is like that. I think we have a pretty much here 40, 50, let's say just 50. So if you do very nice, the physical examination by Dr. Pablo, he can find 5 or 10% thyroid nodules. And that means here 5 or 3 to 5% will detect thyroid nodule. Oh, sorry, Dr. Pablo, and then what's the diagnosis, something like that. But if we do ultrasound, the numbers will jump up like 30 to 60%. Let's say it's 50%. That means if I checked all your thyroid scan with ultrasound here, I can find 25, 20 simple cyst and nodule, right? So that's why it's not recommended to do kind of health screening of the thyroid gland, as I know. And so in Korea, what happened was there was a promotion. So if you pay $50 or more, they do breast scan. Okay, you can persuade patient. Okay, I'll give. If you pay $50 or more, I can check your thyroid. Yes, it happened. So over 10 years, 15 times more thyroid tumor was detected in Korea, my home country. 15 times more. That means 1,500% increase of thyroid nodules. So all the celebrities on TV show, like, oh, I had a thyroid surgery. And then they show their scar. And then a very young, kind of a bright endocrinologist or surgeon thought that why all of a sudden we have 1,500% more thyroid patient. What's going on? So I'll talk more later on. So that's why government and all the societies got involved, like surgeons, endocrinologists, and then so radiologists. Okay, there's something going on. We should stop, slow down. And then now it's trending down. So I'll talk more later on about that. So this is a reality. So prevalence is the same. We have the same, disease, prevalence, but we are, by more diagnosis, we are moving to more treatment. So this is a very, as I know, most cited paper about natural history of thyroid nodule. So what will happen if you do not have a surgery? If, let's say I have a benign nodule, what will happen? Very importantly, as you see here, 1,500 patients they follow up. 11 patients, they saw the tumor were growing. And then 75% tumor is stable. 13%, even the benign nodule is shrunken. So, and then they ask, and how much tumor changed into the malignant over 5 years, the 1,500 patients. Just only 0.3, 5 patients. But even among 5, 2 are from another new nodule, and then and from the other, the recurrent, apart from the primary, the nodule. So that means, as you agree, it's very indolent. It's very grow slowly, and then it's okay even to do surveillance and follow. So, but if you see the statistics in the United States, how many thyroidectomy a year? They do 150,000 thyroidectomy a year in the United States. Maybe now more, it's all the statistics. And then if we dissect, we see more, okay, and then how many benign, how many malignant nodules? 2/3 of the nodules are benign, pathological, surgical pathologists, okay, benign, malignant, yes, 2/3 are benign. That means 100,000 thyroidectomies were for benign nodules. If you divide the 36.5 or 250 days for working days, every day 300 thyroids are, boom, the surgeons are harvesting 300 benign nodules, whatever, lobo, kind of hemi or a total thyroidectomy. So, and then if you are a patient like is it okay if I take my thyroid out and take a lifelong medication? All the ideas start from that, point. So, and in the United States, outpatient-based thyroidectomy, it'll cost about $7,000 or $8,000, average, $7,000. And then if you add more kind of a fee from the general anesthesia, it will about cost, $1,000 or sometimes $20,000. It's a lot. So in the market in the United States for the benign nodule thyroidectomy is almost $1 billion market. Minimum 500 million market or $1 billion. So there now doctors are taking the money by the thyroidectomy for benign nodules. They're on the money $5 million or $1 billion money for benign nodules. That's the business going on in the United States. So, as we agree, there's a hormonal therapy, but it's not recommended by the even American Thyroid Association. So, it's a non-functioning, no surgery, but it's growing, and there's a mass effect like a choking, and then surgery. For the functioning thyroid nodule, it is recommended for radioactive iodine, but there's a 20-30% complications of hypothyroidism after radioactive ablation. So, and then we can think about, is there any option to spare or save the thyroid except those tools? Yes. We have ablation. So, you can ask, what's the big difference between existing radioactive iodine or surgery and ablation? As you see here, it's very common sense because we do not do the procedure under general anesthesia. Yes, Mayo Group, they did it under general anesthesia, but originally proposed by the guideline of the Society of Korean Society and many other societies, we do not do it under general anesthesia. It'll be just a lidocaine only or IV consultation. Because of that, it could be an outpatient-based procedure. And then 30 minutes. Yes, you can see the patient agreed, and then you can let the patient come another day, and then you can do the procedure within 30 minutes. That's it. And they put a Band-Aid tape, let the patient go home, and then continue their work. That's big advantage. And then downside of it is the same like other surveillance program, but still patients still have a thyroid nodule. You should follow, regularly. Also, the concept of treatment is rather than over-treatment. In other body tumors, we try to kill the entire cells because mainly it's malignant. So we overcook, the nodule and including some normal cells around the malignant, lesion. That's why it's over-treatment. But in thyroid nodule, because it's a benign, I will definitely talk about malignant, lesion too. But for the benign nodule, the concept is under-treatment. The reason why is in a very tight, small space, there's many important critical structures, especially recurrent laryngeal nerve or vagus nerve. So that's why the concept is under-treatment rather than over-treatment. That's why there's a chance for tumor recurrence from the peripheral, the peripheral portion of the tumor. That is big downside. So we can use a chemical, thermal. Thermal means energy, kind of using grill. You can grill the chemical can also kill the cells. So this is all the different tools for thyroid ablation. So, and then current guideline is initially from the Korea, and then Italian group, and then England, and then Australia. So pretty much more countries are now developing this thyroid ablation procedure officially in their communities and societies. If you see some guidelines from a certain country, that means it's pretty much they reached a certain level. So hopefully next year, yes, Mazatlan, Mexico, or Medellin, or Latin America as a group, the guideline is really important for training or instruction to patient. I think that is one of the things everybody should collaborate, to have this kind of very nice instruction, to physicians and for patient. Oh, does it not move? Hey, Marco. Okay, good, thank you, yeah. So, in the United States, 2016, finally they accepted the laser ablation and RFA, radiofrequency ablation. They recommended if the tumor is not responding, it's rapid growing, and then it could be a very nice tool. And this is a comparison table of the guidelines. As you see, the Korean guideline is most complete, and then Italian guideline is following it, and Australia, nice. The American Association of Clinical Endocrinology is there far behind. Okay, so they're trying to catch up, but there's no task force team and there's no very active, but they're discussing, but still there's no official guideline dedicated on thyroid ablation. So this is a key slide, and you can remember and forget about everything, but if you can remember this one, that'd be great. So the green line is for patient with benign thyroid nodule and then autonomous functioning nodule. And the red light is on primary or recurrent thyroid cancers. But patient refuse, or there's a high mortality morbidity, or there's a high surgical risk, it's potential indications. So another, on the right lower corner, relative contraindications are pregnant woman, and then if you deliver energy, it can affect the fetus. But if you use bipolar probe without making an electric circuit, you can just only work in the thyroid nodule. That's why it is relative contraindication. So patient has a severe arrhythmia or cardiac pacemaker, the radiofrequency can affect the device. That's why it's also relative contraindication. Another contraindication is already patient has a contralateral side. On the other side, there's a nerve paralysis, it's recurrent pharyngeal nerve, and then if you're really unlucky, you can damage the same side, the lesion side, recurrent pharyngeal nerve. That's why in that case, it's a relative contraindication. In that case, maybe we need the monitoring of the laryngeal nerve during the procedure. Now move a little bit quickly. So I think you're pretty much not interested in basic physics. It's too much. So I chose RFA, radiofrequency, but I like to say laser is really good. So laser has a more the kind of research the research and history and evidence. So laser and radio frequency pulse are good. But microwave, hypo, there's a lack of evidence. We need more research and evidence. That's what I like to talk. So the idea is simple. Our body temperature is 36.5, 37 degrees in Celsius. If you jump into the sauna, it's 40 degrees, you feel like, oh my gosh, it's really hot. Over 40 degrees, starting from 45, cell cannot survive. You check the temperature of your sauna tub, bathtub, always below the 40. It's above the 40, our bodies react very badly. So the ideal temperature for thermal ablation is above the 50. It's great, and then you can kill all the cells. But above the 100, the problem is that there's a charring or carbonization. My analogy, you cook your meat, right? But if you temperature too high, you can see the whole kind of carbonization and then charring. As you should just try to take the whole the carbonization out. That's why above the 100 degrees, then the efficiency will drop. So that's very important to maintain the temperature between 50 to below the 100. So it's very simple. Just you create the electric circuit in your body, like that. So, and then probe will be in your needle will be in the thyroid, but you need the grounding pad, like that. So now we created the electric circuit, and then it's accessed from the neck. And then if you see more microscopically, what it happened is, and then the power is on, there's an electric current, radio frequency, and then it will excite moleculars, especially bipolar moleculars and water moleculars, and then they have 1,000,000 times excitations, kind of moving rotations per second. And then heat is generated, and then temperature will go up. So actually, radio frequency, they just excitate, let the molecules, moves very fastly, and then it is transmitted into the heat, and then heat is cooking the thyroid nodule. Okay, so, and then I like to go to the procedure. Procedure very simple, easy. Anybody can do it, but you should know how to prevent complications. So, because it's a benign, if you make a big, bad complication event, nobody will come to you again, right? What's the most common complication after surgery? Voice changes, right? The recurrent angina nerve or parathyroid gland, like a hypocalcemia. Please, Dr. Sanchez.
No, but in this kind of procedure, maybe the most important complication is the skin burn.
Yeah. Skin burn?
Yes. Kind of complication, you can go to damage the radial nerve.
Yeah. So common complication and serious complication, I like to little bit separate. Most serious complication is the laryngeal nerve, some injury, something like that. So, all right, I will discuss more. Thank you. And then this is how I train my fellow. It's right side me, it's my fellow, and I train how to do it. So I like to explain about the two key techniques and how we control the pain during the procedure. It is not going to be under general anesthesia. So usually you can find the tissue fascia between thyroid and strand muscle, and then you can put a 25, 27 gauge needle, and then you can put the lidocaine, 5 to 10, sometimes 10 to 20, and then you make a water barrier or lidocaine barrier to protect strand muscle and then vagus nerve, sometimes recurrent laryngeal nerve. This is very important to protect reduce the pain during the procedures. The thyroid lidocaine injection first. And then another two very important key techniques are trans-ischemic approach. That means from the central, we go to the lateral and far distal. The reason why is during the procedure, we want to check the patient's voice. So I usually sometimes ask, what's your name? And then can you tell the date of birth or something like that? And then to check the patient voice is okay. So during that kind of voice check, patient talking or patient swallowing, and then because the thyroid is encased by the fascia, when you say something or swallow, thyroid moves up and down. So that's why if you go directly from top to the bottom or from lateral to the medial, during that checking, the needle will be moved out or the position of the needle will be changed. But if you move from the central through the normal thyroid, then nodule, that needle is held by the normal skin and thyroid tissue, needle is very stable. That's very important. Another key is recurrent laryngeal nerve is, we call it at the tracheoesophageal group. We cannot see the nerve. The recurrent laryngeal is so tiny and small, we cannot see the nerve itself, but we can guess where the nerve is. That's why if you approach from the middle to the lateral, we call it dangerous triangle, where the recurrent laryngeal nerve is automatically protected. That's why if you read the articles, most complications are from the procedure directly from top to bottom or lateral to medial, but it is very close to the dangerous triangle. So then once heat is created, it has a conduction, so it's hard to control the energy conduction when it is created. So that's the kind of thing. So, and then another thing is very important technique is a moving shot technique. That means in the other part, tumor in other part of our body, just we put the needle in, just wait several minutes, and it will cook the tumor very nicely, including more of the surgical margin. But thyroid nodule is not that round. Thyroid nodule is more like an oblong, like an egg or some potato or something like that. So if you just put a needle in, just wait, you cannot treat the entire the nodule. Another problem is if you overcook, you can damage the critical structures. So that's the, let's say the yellow one is benign nodule. If you treat too much, you will damage the trachea, esophagus, and the vascular structures and nerve. That's why concept of a thyroid nodule, benign nodule is under treatment. So, and then moving shot technique is you just divide the area or zone of a nodule into the multiple small units. And then you can put a needle in, you think it's done, move to the next. That is a concept of moving shot technique. So I'd like to show the video here shortly. Can you help to play the video? Sorry. Yeah, there's some issue with the video. It's fine. Yeah, thank you. Yeah, usually needle comes from the midline and go to the far, and then the needle will, you can see that it's a back and forth. So the recurrent laryngeal nerve, as expected, there's a trachea, and then recurrent laryngeal nerve is around there. So in this case, the thyroid node is relatively safe away from the recurrent laryngeal nerve. That's fine. Thank you. Yeah, I need to check it. Okay. So then, if you're interested in thyroid nodule, you need a policy, strategy. And then, so we have many different nodules with a different component. So usually, when the component, so just only focus on the solid component, okay? So when the nodule is made of more than 90% cyst, we call it cystic nodule. And then the solid component is less than 50%. We call it predominantly cystic. Still, cystic component is more, so we call it predominantly cystic. the solid component is more than 50%, we call it solid nodule. So the reason why we divided into the cystic, predominantly cystic, solid nodule is even we do the same procedure, thermal ablation, especially RFA, different result. That's why we approach differently. That means what will be the best? Thermal ablation versus ethanol ablation. That's why it's very important to remember this strategy. So let's talk about first the cystic and move to the next. So 10 years ago, 9 years ago, now it's a classic. So they did the cystic nodule, they did the RFA, and then result is ethanol ablation is better. It's 1.2 times, multiple sessions, only 1.2 times, but RFA need more sessions. And then volume reduction is, as you see here, ethanol ablation is 93%. So that's why less sessions is more volume reduction, why we do thermal ablation. So for the cystic thyroid nodule, definitely ethanol ablation will be the best. So this is another study, ethanol versus thyroid ablation. Yes, the same result. Ethanol ablation group has a better volume reduction. So cystic lesion, ethanol. So now we move to the predominantly cystic lesion. And then this is a study by Dr. Beck. As you see here, volume reduction, the radiofrequency, ethanol ablation, both are quite similar, neck and neck. So RFA is not much better than ethanol ablation. And then why don't you start, with the ethanol ablation first? It does not work, maybe you can move to the thermal ablation. That's the concept. So as you see here, the more solid component, its solid components approach the 50%. And then the efficacy is really dropped. So that means more solid component, we should think about thermal ablation rather than ethanol ablation. So guideline is for the predominant cystic, you're comfortable, you can do the RFA, otherwise start with the ethanol ablation first. It does not work, you can do the RFA, or you can aspirate fluid first and then combine therapy, ethanol first for the whole the cystic lesion, and then only leaving solid component, you can do the thermal ablation. Yeah, definitely for the solid nodule, as you see here, RFA has a volume reduction 84%, ethanol ablation has just 38%. The reason why is if you inject ethanol in solid component, the ethanol goes very uniformly, it's hard to predict the ethanol will go where. That's why RFA, if you put the needle in a moving shot technique in every corner of thyroid nodules, you can have a better result, with the RFA. This is the standard. So more than 50% of solid component, RFA, between cystic and the solid, ethanol versus RFA is totally your choice. But the more solid component approach to 50%, RFA is more strongly recommended, or combined therapy is recommended. So now you have the whole the key techniques and the procedures. Now go to the evidence. So according to the systemic review or meta-analysis, how much volume reduction will happen over a year after thyroid ablation? 80%. You will have the 80% volume reduction after a year. So most important thing is happen over 3 or 6 months. My protocol is follow the patient 3 months, 6 months, year, then yearly. So if you see the volume reduction over 3 months, 6 months, it will be stable. The more volume reduction. After another 6 months, till end of the year, you will have a 70-80% volume reduction. Then over another several years, you will have a 5 or 10% more. That means it's really well treated, 9% volume reduction. So, but if you check the patient at 3 months or 6 months after procedure, there's no much volume reduction, and then such a kind of gradual volume reduction will not happen. In that case, you need another second treatment session or think about other treatment option.
The current point is still 50%? To consider it a successful treatment?
Yes. 50% was really, it was arbitrary. for the tumor volume reduction, 50% is a lot for the malignant tumor. But the benign tumor, 50% we call it therapeutic success.
Could be good for you, but maybe not for the patient.
Yes. The reason why it's like that, the thyroid volume, we usually measure the only diameter. But if you see the other very nice, the clinics, the thyroid, report, they always, put the volume. So as a diameter increases like a 1 cm, 2 cm, 3 cm, 4 cm, 5 cm, the volume increases like this one, exponentially. That's why if you treat a 5 or 4 cm nodule, if even you have a 50% volume, the diameter is from 5 to 4. So that's the totally different. Even in the 50%, yes, as Dr. Sanchez told, nothing. Yes, that's the reality. So that's why therapeutic success is really old concept, But now we should more focus on the symptomatic, improvement. And yes, thank you. So, yeah, we have a tremendous, the kind of evidence. Dr. Beck group, they follow the patient, 276 patients over 5 years. If you follow patient for a long period of time, there are a lot of dropout. Yes, over 5 years, they have only 5. That's hard to say 95, but as you see here, first year, 84%, second year, 9%, and gradually they have more and more. So complication is one, major complication, one. That means 1 out of 100, you will have major complications. So I think this slide is not right. This slide is given from Dr. Beck, and they compare RF and laser. But laser started earlier. They try to do all kinds of tumor, not large and small. So if you see all the details of study, depending on the patient population, you will have different results. So don't be biased by only the result. It's very important to see the population. Okay, so this is a slide made by Dr. Beck, not by me. So he wanna prove that his RF is better than laser. Okay, so he said more volume reduction over a long period of time, but this is not true. And then this very nice systemic review and meta-analysis published 2 months ago, and as you see here, both RF and laser are good, no problem.
And in the last picture,
Yeah?
there is a very important thing,
Yes.
the size of the node.
Yes.
It first, cut the small size,
Yeah.
but automatically cut the bigger
Yeah.
size.
Yeah.
20 centimeters is a huge node
Yeah.
versus 8 centimeters. It's a very different into the successful.
Yes. Common sense is we treat the tumor nodule with a smaller size, the result is better.
Yes, sure.
Yeah, we treat the bigger, larger tumor, whatever laser, RFA, the result is bad. So that's why 2013, Dr. Vakalvi is really known for expert in laser. He realized a larger tumor, depending on how you put the needle for the laser ablation to the corner, the treatment result is different. So you are more diligent in treating all the peripheral portion of a tumor, you will have a great result. But that means, your tumor is larger, you do not treat the very diligently all the peripheral portion of tumor, you can expect tumor recurrence. That's my but smaller one, like a volume less than 30 millimeter cc or 20 cc, both, RFA laser has the same, the great result. That's my idea. So that is very important. At 6 months, you have great result. It is all maintained. You have more and more volume reduction. But 6 months, you do not expect 50%, more than 50%, 6%, and then think about second treatment session. So, and this is another very nice study published the March this year. As you see here, volume is lower, small size nodule from the beginning has a much better volume reduction than larger one, because the larger one has a peripheral marginal tumor regrowth. So this is the result. So, and then you can ask what will happen inside our body. Yes, gradually the dead tissue will be absorbed by the macrophage, and then later on you will see the very tiny scar, like almost nothing if you follow patient long period of time. This is really well treated case. So, and then safety. Because this is benign, you shouldn't harm the patient. It's really key. The serious complication, this is the largest risk for the complication. It's almost 1,500 patients in Korea. They collected all the data and they published. So this is a number, but if you see more details, the red ones are major complication. Yes, patient, there's an abscess, there's some issue with the sterile technique, and then it ruptured, and then patient should have a surgery. That's major complication. And hypothyroidism, there's a lot of debate. So during the pre-workup for thyroid ablation, we recommend autoantibodies. The reason why is if you treat patient who is on the middle of autoimmune disease and then thyroiditis, then later on, it's hard, without such autoantibodies in the lab, it's hard to prove that. It is in the middle of process, there is another, you treat it, and the patient progress to the hypothyroidism. That is strongly recommend. It's debatable, but antibodies are recommended before the procedure to protect, your business, Yes, to protect, to prove that. But all the papers show that it is not related with laser or thyroid ablation. It's just safe. That means it not affect normal tissue. So voice changes happen 1%, but gradually all of them are recovered over 1 or 3 months. So, but there's a permanent damage. After 3 months, you cannot see any recovery. We call it permanent damage. So it is a really serious complication. So, and the other, the small hematoma, skin burn can happen. It's all manageable. Over a couple of weeks, you can put the ointment as the burn. It's like a skin burn, it'll be fine. So it's possible. So, and then we can protect nerve or prevent nerve damage. So one is you should be well aware of the nerve anatomy. So I don't know, I have a chance to show you, but there's a vagus nerve. You can see the vagus nerve. Very interesting. You can see the vagus nerve between jugular vein and carotid artery. But you cannot see the recurrent danger nerve. The recurrent danger, just guessing, or between the trachea and esophagus, lower portion of thyroid, dangerous triangle. You should assume when you treat nodule adjacent to it, you should put some water barrier, like a hydrodissection, something like that. That's only the way. So know the anatomy first with ultrasound, and then protect it, and with a hydrodissection, and then use the key techniques. So, and then if you're not comfortable, you can check the voice change. There's a voice changes, or just turn off the light, just wait, and then just turn on the power. We can go to the next. So this is all the nerves. The more you treat, like rather than a nodule in the thyroid, more complications in cases of recurrent laryngeal nerve, or especially recurrent thyroid cancer or nodular lymph node metastasis, because there are tissue adhesions and the nerves adhesed, especially in the central, the zone or compartment, there are chance for more of the nerve damage. In that case, you need a very detailed anatomy and hydrodissection. Sometimes maybe you need the nerve monitoring. It should be very careful. There's more complications are reported in recurrent thyroid cancer or when you treat lymph node metastasis. So this is a clinical result about the autonomous functioning benign nodule. So non-functioning nodule, our goal is a cytoreduction. That means we reduce the volume. Even you treat incompletely or partially, you can say it's a success. But functioning thyroid nodule, our goal is change into the euthyroid. So that is more challenging. So if you leave a functioning portion of the nodule, still it is you can make a euthyroid. Some patients still have a TSH a little bit suppressed, and then the T3, T4 is upper limit, something like that. So our goal is, the hyperthyroid patient in a euthyroid status. That's why for the benign nodule cytoreduction, volume reduction, 50%, 6% doesn't matter, but in functioning thyroid nodule, you try to ablate treat the more complete volume of the nodule. The problem is, the bigger the size of a nodule is, you have more failure, different from non-functioning nodule. That's why it is recommended to try to select the patient for the functioning thyroid nodule, like a volume less than 13 or volume less than 10 millimeter. Try to treat the very small functioning nodule. The volume increase more than 13, 15, close to 20. The success, I mean the changing into the euthyroid state is really, really, really drop. So that patient selection is really key in functioning thyroid nodule. You should select very small size. That should be a very smart way, to do. Okay, this is another report. So they did a comparison study of radioactive iodine and the radiofrequency. So both are good, 90% and 70%. They achieved the goal of functioning like a euthyroid state. But the problem was, yes, as you expected, in the radio ablation, there's a 20%, the hypothyroidism. That's the advantage of the radiofrequency. So now we're very close to end. So the benign thyroid nodule is very classic now. It's a standard, So only debate is what kind of tools, like a RFA, laser, or microwave, mainly from China, microwaves, or HIFU. So just only remaining things, what kind of tool are you going to choose, for thermal ablation? So now I'm going to talk about the malignant thyroid carcinomas shortly. So as you see here, for the malignant thyroid lesions, standard is surgery. Nobody recommend, thermal ablation at all. But when you think about the complications and think about patient quality of life, and then there's a lot of dropout during the follow. So it's hard to follow a patient with a malignant primary lesion 10 years. Even it's indolent, it's hard to have 10 years, 15 years of follow. If you see the Japanese active surveillance, the primary lesion they follow, after 15 years, they start with the 300. At the end of their active surveillance, they have only 2 or 3. That means nobody want to come to your clinic, comes to your clinic. Just you say, after every 6 months, oh, it's okay, your lesion is fine. And then come to me 6 months later on the patient, what kind of lesion is this? And then they just, not back to you. That's one of the things. So now people are looking for what's the role of ablation. So if I talk about the recurrent thyroid carcinoma, the recurrent thyroid cancer in 2 areas. One is a central, neck, after central neck dissection, the tumor recurrence, thyroid in the central area, and the lateral areas, there's some lymph node, recurrent. So role of thyroid ablation is improve the quality of life and reduce the complication if patients are non-surgical candidate or refuse, or there's a high mortality. So there's 2 concepts in treating recurrent thyroid cancer. One is complete. Complete means, with the imaging wise, if you do follow up the ultrasound detectable or CT detectable nodules, it's no more visible. It's gone. That is a concept of complete treatment, not the micro, kind of a cellular level. It's just on imaging level. Another one is conservative treatment. It's like a palliative. It's a tumor too large and it's compressed adjacent structures and tumor is growing too fast, as a palliative treatment like radiation therapy or surgical therapy or radioactive or hormonal therapy, just the palliative. So, and then I did a research on how many cases have been reported worldwide so far. Only 228. And my question is, can he have a conclusion, with only just 10 report, only 228 patients, we can say what is better? No, I think we cannot. And then also, complete disappearance is range from 25% and 91%. So, but number-wise, we want to restrict the number less than 2 or 3. More than lymph node metastasis is more than 2 or 3. surgery is much better. So only we treated a limited number lymph nodes. So this is the first case, and then this is complete, image-wise, complete treatment concept, and then this is a palliative, just a palliative treatment because it's encroaching the trachea. So put the stent first in treatment. This is a palliative concept. So clinical outcome in the recurrent thyroid cancer, radiofrequency versus ethanol, both are good. But as expected, the ethanol has less complication. So that's kind of thing. But RFA will have a less, the sessions because RFA can treat more, ethanol treat less. That's why there's difference. And then, so then ethanol ablation versus reoperation. Yes, reoperation definitely has more complications, but ethanol has a less complication. But recurrence rate is pretty much the same. Yeah, ethanol is good. The lesion is small. And then finally, Dr. Kim from Korea, he compared the RFA versus reoperation. So as you see here with the statistical kind of adjustment, yeah, pretty much RFA is good over reoperation. So, and then very nice alternative, really, there's some high risk mortality and patient refuse to surgery or surgeon is really uncomfortable doing reoperation after central and lateral neck dissections or repeat surgery. It's really, yes sir.
Do you think that this is a very good option for central neck recurrences?
Yes, but
And it is safe thinking about the recurrent laryngeal nerve?
yeah, central neck recurrence, in case of central
But
neck
this is the
recurrence,
dangerous recurrence.
yes, it's a more complication
Yes.
if we treat the central. But the lateral, neck, the
Okay.
lymph node, it's just safe. But the central, you have more complication. So they reported only 6 cases.
Okay, but
So, yeah, not large volume, yes. But centrally, definitely, you expect a more complication.
because it's impossible to know where is the recurrent laryngeal nerve
Yeah.
and his relationship
Yeah.
with the nodule.
Yeah. That's why surgery or nerve monitoring is safer than RFA.
Okay.
So that this is a summary. Okay, RF versus ethanol surgery. Yes, now it's a common sense. RFA, the less sessions, but complication-wise, ethanol is the safe. Yes, central depending on the where you treat it, there's a difference. Yeah. All right.
Central or central lateral, it will be different.
Yes. Yes.
In the first line there was when the needle recurrence is accessible to your needle in the first word. Is this accessible for the needle? You can do the procedure. If it's not accessible,
Not only because it was very, very, very high risk with the recurrent laryngeal nerve. This is the
yes,
issue.
it's so
This
close.
is the
And
issue.
yes, I feel more comfortable if it is in the lateral neck, not in the
Obviously.
central neck. Yes.
But
More comfortable.
we can have one in the central compartment, but lateral or with some millimeters of distance between the nodule and the trachea.
Yeah. Yes.
This is a risky area.
Yes, it's a risky area, yes, and I suggest in this kind of nodules, recurrence, to not work with radio ablation or laser or even chemical ablation. I prefer the surgery than the difficult to decision, but I prefer the surgery than the ethanol ablation or alcohol ablation.
Yes. So we are not comfortable in the central compartment. Yes, ethanol is good option. And another way is technique for the RFA is you put a needle and then put the dextrose in 5 water and then make a hydrodissection. Another technique is you can push and pull and tilting the needle after put the needle in and then let your target away from the key structures.
And
Yeah.
you can in the same time check the vocal cords
Yes.
with sonography in real time in order to do some degree of change of movement.
Yes.
The vocal cord.
Maybe the damage is more important than the thermal because it's so close to the laryngeal nerve and the transmission of the thermal damage is not easy to control in this side of the neck. It's more difficult, it's dangerous for the patient. If you don't cut in the posterior in the laryngeal nerve, you can damage it in the incision. That's what I don't prefer to do. I prefer to do it in the lateral compartment.
Yeah. For the the lateral compartment or their chance for a spinal access nerve or kind of a sympathetic cervical trunk is more superior middle, and so there's many nerve structures in a recurrent the thyroid cancer. So that's why more complication than just the benign nodules. So yeah, thank you for discussing all the details. So primary thyroid cancer, yes, we can do it, but only 168 patients, so small volume. Yeah. And yes, he's Dr. Sanchez. He's preparing, maybe so. And then all the large volume is from China. China, they can treat all the primary nodules without active surveillance. It's hard to believe they treated 90 and 30, something like that. So, but there's a big caveat. So, Dr. Barkalby, he treated 3 nodules, and later on, he had a chance to see the surgical pathology. Patient had a surgery, and then multiple tiny cancers in the other part of thyroid gland, all the lymph node metastasis. That means we are treating only ultrasound visible tumor. We are not treating the microscopic tumors already metastasized to the gland and lymph node. That's very dangerous. After treatment, we're like, oh, we are fine, but actually not fine. And then another report from this group, they also, checked all the 11 RFA and microwave. Yes, all the tumors has a residual, cancers and lymph node metastasis. That's why there's a lot of debate. Primary region, we should not treat. Other groups, we should treat. Because active surveillance is, local control is fine, but it's limited because multiple metastasis intragranularly or lymph node metastasis. So, okay, so one of the things I like to discuss is active surveillance, from Japan now in Sloan Kettering, Dr. Russell. But Dr. Russell's, the kind of his comment was also there are a lot of dropout, the loss of the follow. So active surveillance is, I like to say, like it's a psychiatric ablation. As a physician, we are doing nothing. We'll get the money and then we give our information, trade our information, but we're doing nothing. What you're doing? Okay, then ablation group say like, okay, rather than psychiatric ablation, we treat the primary lesion, even there's a microscopic, intragranular distal metastasis. When it's apparent, even we do the surgery, it is not late, Repeat surgery is very challenging. After lobectomy, whatever, usually surgeons prefer total rather than hemi and lobo. The society recommends please do lobo, hemi, but surgeon, it's very comfortable. It's like a total thyroidectomy. So that's the concept is rather than active surveillance, new paradigm, it has also limitation, kind of a lot of loss of follow-up dropout. So that's why now so we need a very nice guideline or consensus, what you're going to do with the primary lesion. It's early to say the role of the thyroid ablation, but definitely my feeling is that for the recurrent thyroid nodules, the numbers are less than 23. It's worse, but you should be very careful in taking control of the complication. You shouldn't make any complications. So pretty much Dr. Bancroft, he published this year about in pediatric population, there's not many thyroid nodules different from adult, but in children, if you do a thyroidectomy, it affects the whole the development, the bone and everything. That's why Dr. Bancroft, as you see, over 10 years, he just collected 14 cases only. That means there's not many, but if your partner is a pediatric hemato-oncologist, if they have a patient, before moving to the thyroidectomy, in that case, we need a very nice general anesthesia and the nerve monitoring, different from adult. For the pediatric population, we cannot control the whole the kind of sedation and everything. So this is what I have tried so far in the United States to keep the thyroid healthy. So my goal was to this procedure practice very popular, active within 3 to 5 years. The problem is revenue and finance whatever money. So mostly denied by insurance companies. Now I just, not by me, by hospital collect the money from out-of-pocket patient directly, but it's too much. But thyroidectomy is accepted, approved by insurance company. There's a huge difference. So, and then another very important thing is in the United States, in New York, all the groups, started their practice, like New York, NYU, Mount Sinai, and the Columbia University, now the Presbyterian Columbia University, also Sloan Kettering. They're now going to get started. So this lecture is the same I gave to the Sloan Kettering. Last Monday, I was in Sloan Kettering, Memorial Cancer Center, and then I gave the same lecture, more focused on the primary recurrent thyroid cancer. So they're not interested in benign nodules. It's very interesting. They do not even a single thyroidectomy for benign nodules, all the malignant, the tumors. So, and then now in the United States, all the big hospitals group, they started because they saw the vision. This is going to be a future of the, especially benign nodule, for the malignant, carcinomas, maybe recurrent, maybe in the future, primary lesion. So, and then my kind of a talk today, or my suggestion is, you are not behind. You are not, if you start this year, early next year, already Dr. Sanchez, like Italian, he have been doing this with a laser. So modality-wise, to me, it doesn't matter. You can learn from laser or RFA. Both are proven, so it's okay. But clinical experience is really important from Dr. Sanchez. But with the tools, how to you deal with the tools, reduce the risk of complication, yes. So if you work together very hard, I think you are now pioneers in your area, in your countries. That's why I like to talk. And so don't regret. Don't regret 2 or 3, I should have started, when I heard Dr. Park's talk, and I should have started, but it's already late. So this is a great, time to get started. That's why I like to talk. So one last thing. So as you see here, disease prevalence is the same. 10 years ago, 20 years ago, we had the same thyroid nodule, the same numbers. But as you see in the United States, it's NIH statistics, or this is from the other papers. Now the treatment is going up crazily. So what happened? Really, we have more thyroid nodules cancers? The answer is no. We have the same number of, maybe a little bit by some environment, maybe we have a little bit, but too much, Everybody has questions. So, as I mentioned first, in Korea, 15 times more. It is not the epidemic of disease. It's the epidemic of overdiagnosis. Because of overdiagnosis, we are moving to overtreatment. We should think about, really, we are treating the increasing disease, or just we are treating the same number of diseases more over aggressively because we found them with the development imaging. So I am 53, maybe Dr. Sanchez, everybody's, has more experience. So I think for the thyroid, my impression, especially in malignant lesions, less is more. Also for the benign nodules, there is no need to treat. We should persuade the patient. But we are dealing with not only the lesion, dealing with the patient anxiety. Anxiety, like, I have a tumor in the breast, it's the same like breast and thyroid. What can I do? So it's very challenging, to persuade the patient just to follow like active surveillance, whatever. It's a benign, malignant. So, but I still feel like I'm not a specialist in endocrinology, like a surgeon or endocrinologist, but as a radiologist, according to my study research, less is more. But I always think about when I should intervene for treatment, not surgery. Like a radio ablation. So the most important thing is, when you try to decide what is the best for the patient, you should have love. I think the same like the patient is my mother, father, my family members. What is the best? So that's why this is my last message. The the secret ingredient for your practice, whatever you do, surgery or radio ablation, is love toward the patient, the same like you. So yeah, I think we'll discuss more, but thank you so much. Yeah.
Congratulations for your lecture. It's very important for me. But maybe the most important message in your lecture is that it's preoccupied that it's going to start, a lot of people work with this kind of exciting technique for the thyroid ablation disease, even benign or malignant disease. I think that it's the time for maybe you that are the top in the US in this kind of procedure, maybe there are another tops in Brazil, there are many tops in Latin America working with radiofrequency and laser ablation. But we must to select the people or the doctors who can do the procedures. We must be select in the training people that are going to do these procedures, and the most important thing is to select the patient and the thyroid nodule. It's not going to be, for me, a popular procedure for all the people, and not all the people can offer this kind of procedure. So this must be very careful with the people we are training. We always be with people we are choosing for do that procedure, and choosing with a lot of cautions what kind of thyroid cancer tumor, micro cancer tumors we can select to offer this kind of procedures. That's my message, doctor.
Thank you. The reason why I'm here is I'm invited by the whole of very nice people here. So I have a plan. In the United States, we just started. I have started 3 years ago, but most important thing is, as Dr. Sanchez, he mentioned, so guidelines, a clear understanding of guidelines from the community society. Another second thing is a training program. So if you collaborate, you can teach the very nice, safe techniques, you can learn each other. And third thing is a national data registry. And then so if you do 5 or 10 cases a year, the number volume is not enough. So that's why you need a very nice protocol for the clinical trial. You can collect all the cases, from the certified or well-trained physicians. You can easily collect, 50, 100 cases. You can publish, internationally, in other journals. And I think my focus is public awareness. Now that in the United States, they only find me through the Google. That means the public awareness not enough. I have the patient support group in Facebook and YouTube, something like this, now different. The second thing is physician awareness. You also train other surgeon endocrinologists just about this one. The third one is, let's say, I want to learn, how to do it, and you should have a training program. So now I'm developing a workbook, like 10 to 15 chapters in the English version first, end of this year. My plan is, have a Portuguese and then Spanish version, and I like to just, share the whole of my training program. So, yeah. Also, really, and then there's no need to invite, my final goal is there's no need to invite me anymore in Mexico or Latin America, any country. If you have a build-up expert, a specialist in your home country, and then you have a guidelines, very nice education program, that's it. And then I expect I'll see a lot of very nice report papers from your home country. So please take advantage of me as a kind of media or bridging, kind of person to set up all these kind of things. Actually, I have a training from Dr. Beck, so he gave me all what he has, and still I'm communicating very closely. So, but he mentioned that because of physical distance from Korea to here, Latin America, I know he visited Brazil a couple of months ago, but he told me it's very hard for him to come here, but he's happy to, at least once a year, he can visit and give a talk. But my mission is to deliver his all the great clinical work and message to your people who needs medical need for thyroid the ablation. So thank you. Yeah. Any questions? Anything else? Sorry, I took too much time.
No. Thank you very much, my dear friends. Well, vamos a continuar con Carlos Simón. Vamos a ir almorzando mientras tanto. Queda una conferencia más de Carlos Simón, una conferencia adicional del doctor Tomimori acerca de la vigilancia, y después de eso vamos a empezar con el taller práctico. Thank you very
Thank
much, my friend.
Thank you so much. Yeah.
Our honor. Carlos Simón.